at that point, that's when we implemented GP triage, and it was quite it seemed like a huge change at the time. But the way when you go back to your question around the appointment books, we took the quite purest version and used those tools around measuring the acute demand. So just got the patient services team to see how many people wanting same day appointments, and we still do that. Like, I think the fundamentals are really, really important to the triage model, including how it's evolved now. So we got the GPs on board, did all that stuff, and started out with GP triage in the morning. We just adjusted the appointment books to say, if Mondays are always busier, and kind of just did the maths on it, which was quite straightforward. And I found that was just really effective, and patients really liked it. And but we're, all the usual things about being worried about whether they get charged for prescriptions over the phone, all that. And so none of that, no complaints, nothing. It was just smooth sailing. We do have one of the really critical parts of it is, at a big centre like this, is we've got a person who is solely responsible for organising the appointment books, and also we gave the GPs a reasonable amount of flexibility around how they wanted to do it, based on the idea that giving GPs control of their day is still a fundamental part of the healthcare home approach in the way we work now. So they still have quite a lot of flexibility around that, but there's always everybody knows and understands that the triage needs to happen first thing in the morning, and we measure our phone calls. So I think Chris has just got a few numbers around that, so we can get anywhere between 500 and 1,200 phone calls on a Monday, and so you can, it's just massive volume, so we've got to have a really good system around it. So, and then I think through that, it sort of just generated a culture of quality improvement, which is what you want, because I think we have got a culture of quality improvement. If you see something that can be done better, people just feel okay about trying new things. We don't spend too much time on it, but we just go, let's give that a go. Sounds like a good idea. So we
not being afraid to fail at having change. If it doesn't work, you can always go back to what you were. Not being afraid to have a go at change.
And so I think it's just really evolved over time, and we've added on new things like, of course we've started extending the team, so we've got the physio and paramedics, we had healthcare assistants right from the start, clinical assistants, and so we've moved from a very traditional GP model where all the GPs just looked after their own patients, and the first port of call was just putting them into a GP appointment, to a much more sophisticated system of triage, still based around the fundamental healthcare home models, but that whole thing about who's the right person to be seeing this, is it the physio or the paramedic or the nurse. And I think what a lot of practices have done is sort of put a GP on the day sometimes to respond to acute care, and the difference with the paramedic role is I think it enables more team-based care. So rather than the acute GP feeling that they need to provide a full care for that patient in an acute setting, the paramedic deals with the acute presentation and then works with whoever in the team to resolve it. And whereas GPs don't have quite as much time to do that because their books are already stacked, and and they've got different skill sets. So I think it's just my lay view of it, but I think they probably feel more that they have to provide a comprehensive care approach, because that's the way they're trained. And then the nurses have got a different skill set, whereas I think paramedics tend to deal with the presenting stuff and then pull in people to be there as the care team going forward.
One of the first things I think I said to Nikki in our first meeting was the medicine side of it's the medicine side of it. We can all do that. That's what we've spent our life training. But what is the business side of it behind it? What's the sustainability? What are we actually bringing it into resolve? Because if there's nothing to fix, then what do we want to achieve out of it? And Feilding's a relatively big centre. We have a large population enrolled. We are in an area where our hospital is working far outside its capabilities. It's extremely busy. So more and more people are not just dropping and going to ED. In fact, it's the opposite. They don't want to go anywhere near the hospital, and so they're turning up to a general practice and looking for care away from the hospital. And it was increased. It was your general illness where now you're getting septic patients walking through the door, you're getting patients walking through the door with chest pain, you're getting patients walking through the door with head injuries. So when I came on board, we basically had a blank piece of paper, and we thought we'd try the first 3 months to see how it would work. And with triage and things like that, it's our bread and butter as paramedics. And so we're not afraid to walk in and go, okay, there's 20 people, let's start at A and end up at Z. And so those sorts of things are sort of easy in our training to go, okay, this is a priority, this can wait, this doesn't need to be here today. A lot of people think that triage is done by a nurse or a doctor, but we round it right back to our business services and our patient services team when they're on the front counter or on the phones taking phone calls. And so what we implemented was the ability for them to cut out the waiting time for certain things. So if people used keywords like shortness of breath, sounded like they were short of breath, chest pain, slurred speech, anything along the lines of sort of like the 5 or 6 emergency type things, then at that point they stopped the phone call, put the patient on hold, and rang directly through to myself and said, look, these are the symptoms they're telling me they've got, what do you want me to do? And so based on what I'm being told, I can triage them into whether it's a GP appointment, whether it's a nurse appointment, whether it's to come in immediately and see me or see me later in the day, or we will hold the call at that point and go, it's not immediately life-threatening, immediately serious, let's put it through to the nurse triage team. And then we've got different levels of triage at the nurse level. So it can go through as an urgent triage, so the very next call must be the urgent triage so that we can get some more information because we haven't managed to get that through the initial phone call, or it's a standard triage. So there's 70 slots a day for nurse triage, and on average we're taking about 800 calls a day. So Mondays are generally just over 1,000, most days are sort of between that 600 and 800 mark. The amount of appointments available for GPs varies because of the work schedules that they have. So we don't have the same availability of acute slots every day. So that's assessed every morning prior to starting. The nurse triaging team gets that list of available slots. We don't include our paramedic slots in that, so we now have 2 paramedics here on site. And we use those very much as a open for anything that's emergency, anything that's urgent. And we try and work alongside that patient's GP. So even if the GP's full, we'll bring the patient into a paramedic slot, we'll do the workup, we'll do the assessment, we'll come up with a differential diagnosis, then we'll go and actually talk to that patient's GP and say, hey look, this is your patient, this is what we've found, these are all our findings, this is what we've done, what do you want to do from here? Most of the time the GPs are really, really good with that and they'll go, okay, cool, let's do ABC, or I'll come down and see them because we've done the story, we've done the baselines, we're effectively handing a patient over to them and going, here are your 3 options, which is the best course of action for their patients. Quite often if we have someone come in with active chest pain, they won't see a doctor. They literally will turn up, we'll get told that there's a chest pain. Again, bread and butter for us, we'll do ECGs, we'll put lines in, we'll organise ambulances. We've also got a project that we're working on, or have been working on now for just over 6 months, where we can do troponin testing at bedside. So we're doing a trial for that in general practice, which has not been done in New Zealand. And so we've got that ability under certain criteria to actually stop and pause with the patient and go, this meets a criteria of less than urgent, and so we will go down taking troponins bedside first, and to date the data's looking really good with that. So we've stopped, I think it's about 55 or 60 so far in 6 months of having to have an ambulance trip through the hospital.
It's a massive game changer in terms of hospital demand if you're able to roll that out at urban practices around New Zealand, and it's in some rural practices, and a few urban practices are picking up now, but I mean, imagine the reduction in chest pain in hospital if they were able to do that. Really, it's just as
much as putting as many patients through as we can is what is the ideal situation. A lot of it comes down to the more time demanding and more acute, or the more we have to do with diagnosis stuff, then that's where our skill sets come into, because we're used to doing that, and we can spend a bit more time with the patients and get sort of a better picture around what's going on versus that 15 minutes of, tell me what you've got going on, this is what we're going to do, next person type thing. So we've got the ability to be flexible with time. So if you have someone come in that's septic, that meets the POEC pathway for treating the community, we can sit on that patient for an hour, hour and a half, and it doesn't affect the day-to-day running because we've got that ability to do that. Having the introduction of the script line where they can do that separately, that doesn't get tied up with the nurses and things like that, is a massive change to how we're doing in the past with each individual person to answer the call. And the triaging is ongoing throughout. So we might bring someone in, and we have a lot of training with our patient services team where they know what to look for. So if someone doesn't look well, then they'll actually call and say, hey, I've got someone in this cubicle waiting to see their GP. However, they've hit some of the red flags that we've got looking. Do you want to just come out and have a look? And so sometimes you walk out and you cast your eye over the person and you'll be like, yeah, you don't look so fresh. So you'll intervene earlier, and so they're not sitting in the waiting room. You'll take them off to a treatment room, tell the doctor that when their GP slot is available for that person, they're in this room. Again, you've started doing some of their work out. And sometimes we just carry on with the care for that person and either move them through hospital or deal with them and send them home. If they're sick, it's easy because you follow ABC and you move on. And it's the same where you've got in general practice where you have people coming in that are sicker than chest infection or things like that, and so now they've got to recall the training that they did, some of them 30 odd years ago, on an emergency situation, and that's scary for them when you've got someone who sort of lives and breathes the emergency stuff, and who's now sort of coming into an environment where that's what we would call few and far between, that is increasing in these sort of environments. And so the introduction of the paramedic role has been able to give us somebody for people to bounce ideas off. So it's not a single point of clinical knowledge. So we will get called in by the doctors to discuss HCHs, we'll get the nurse triagers going, hey, I've got this patient, really don't know what to do with them, what do you think? So you become a sort of third view, because your view on things is slightly different. So we had a patient come in with one of the doctors saying, you know, they've had these ongoing headaches, the dad had the same issue, they worked together, and so they were like, oh, we could test for this, we could test for that. And I was like, has anyone tested their vehicle for like carbon monoxide leaking, or has anyone tested any of the patients for anything like that? And they stopped and went, oh, I hadn't thought of that side of it. So they were paying to decorate, and they're like, oh, so what are they being exposed to? What are they, you know, is it lead poisoning? Is it all these sorts of things? They're very, very vague symptoms, but sort of the third world view of it was, have you looked at the vehicle they're travelling in together because they're both getting the same symptoms? Is it a genetic thing? Like, what other lines have you thought down? So it gives that ability to have clinical discussion around things that are outside the 80%. And I think that 20% of where things are just not textbook or not normal is where you come in and you've got a different view because you've seen different things, and you're able to have those discussions. You're not always right, nobody's always right, but it gives that view of being able to open a few more windows and go, okay, are we looking at this from the right way?
I did want to comment on the capacity. It has definitely increased capacity. I think that's quite an important thing for, you know, I hope that policy and funders and decision makers will be aware of that. And we're going to do some digging into the data, but we've noticed a big drop off in our after hours presentations, and there's all this work goes into how to deliver more better after hours services. But if you sort out the daytime demand, then that's the best way to sort out your after hours. So I think once we pull that data, this year's probably been the calmest our after hours has ever been, and it's because we don't turn people away during the day, and then they just come back to after hours. Yeah, so it's 100% increased capacity, daytime capacity, and then had a flow-on impact to our after hours services, and I'm sure it would be ED.
to collaborate with the rest of the team, and becomes a multi-skilled focus on that. So we all do the acute here and now. In the meantime, the long-term condition nurses are looking at, okay, so that's going to be in a week's time we need to do this, and then the GPs are sort of, oversee that and go, okay, cool, so you guys have got that part covered, I'll sort this bit, and we'll sort of come back in the middle. And that's been really cool, particularly for some of the elderly people.
I think it would be fair to say that, and certainly one of the bits of feedback I got a lot was that staff wanted to feel more safe in situations where people present and there's no doctors to see them, and they're scared someone's going to die, and that sort of stuff. And a lot of it, I think, people always follow the pathways, and a lot of it is more perceived risk than actual risk in some ways. I mean, there is actual risk, I'm not dismissing it, but that came through quite a bit in the staff engagement surveys.
Definitely from patients, we were getting some pretty positive feedback, whether it was on social media from staff. The change came quite quickly. So you've got people that like senior clinicians, senior nurses, who initially were probably a little bit standoffish because it was a new role and it was outside that linear doctor-nurse model. But then you'd get a knock on the door, can I run something by you? And you go, yeah, cool. And so now it's integrated as part of 90% of my day is answering queries from the nurses about certain things, or patient services, or the doctors, or it's that whole sharing ideas. And so that's done nothing but grow and grow and grow. And a lot of the emergency stuff, in the past there would have been someone walking with chest pain, an emergency bill would go, you'd have 10 or 15 people show up, that person would get fussed over by 6 or 7, and there'd be this constant adrenaline surge. We introduced the paramedic role, and now it's like, don't worry about pushing the button, just give me a ring, I'll come out, unless it meets X certain point. So we've gone from probably 5 or 6 emergency button pushes a week to we may get 1 a month. Yeah. So that whole adrenaline hit of worlds falling in has been taken out of it. And then when we get that patient with chest pain, they're like, oh, how many do you want? It's fine. I'll do it with one of the nurses in the HCA. We don't need 10 people in the room for someone. So we had someone walk in a month ago who was having a STEMI. We were able to manage that with the 3 of us. We thrombolised the patient on site with the ambulance crew, landed a helicopter in the paddock next door at the school, and the patient was flying through Wellington, and it was just another day at the office for us.